Hello everyone. I would welcome all the participants, and I assume that you are all mostly physicians and many of you are in primary healthcare uh, areas with very few dermatologists, and you must be exposed to many dermatology cases in your practice, since dermatology cases are so common. And even if your cases of a diabetes or a hypertension, they usually have some dermatological conditions coexisting. So today I will try to cover as much as possible among the common dermatological conditions which you may come across in your practice, and we'll try to take some of your questions at the end of the talk. So shall I share my screen now?
Yes.
Actually, I will require the, yeah. So I hope all of you can see my screen, and I will minimize this window. Um, so let's go ahead. I'll be trying to tell you about the various dermatological, mostly the infections, as the infections are what you most likely come across, a few inflammatory, few pigmentary, and few miscellaneous conditions. So as I tell you about it, I'll be using some words like macules. Macule basically means there's only a change in color and there is no raised, or you can't feel it with eyes closed. A papule basically means that it is an elevated lesion, but the size is small, less than 0.5 centimeter, whereas a nodule is something which is more felt than what you can see. So it has a deeper component to it, and it's usually bigger. When many papules coalesce together, they form a circumscribed, that is well defined, solid raised lesion, which is flat. So that's called a plaque. Uh, if you see lesions which are filled with fluid and they are small, then they are called vesicles, and if they are large, then they are called bulla. And with this introduction, I'll try to tell you how to come to the diagnosis of most of the common conditions and how to treat them. So I start first with bacterial infections. I'll be covering a few of them. So in bacterial infections, we need to see whether the lesions are arising follicle based, means the hair follicle, whether the lesion is based around the hair follicle or it is irrespective of it. So first condition is impetigo contagiosa, very commonly seen. It's a type of bacterial infection to Staphylococcus and Streptococcus, occurs mostly in children. What it starts as small vesicles, but they are very superficial. So it immediately crusts off. And what you see is this kind of honey-colored crust, usually over the face. So I'll cover the treatment together for these. Another type of impetigo is where you get large bullous lesions where there's a lot of pus. And when it ruptures, it leaves behind crust like this. So this also is a bacterial contagion, which is infection which is irrespective of follicle. Now coming to the follicle, see this picture is very clear. You can see the hair follicle, and at the base of the hair follicle there is a pustule. So this is a condition called folliculitis, very common in people who shave, those who are diabetics, and this is also caused by Staphylococcus aureus. And the trick to diagnosis is to look at the pustule which is arising at the base of the hair follicle. Second follicle-based lesion is furuncle. So here you have a nodule which will have a pus pointing. When it starts, it just starts as a painful lesion. It's caused by bacteria Staphylococcus only, but there'll be some predisposing condition like diabetes or immunosuppression when a person presents with multiple furuncles. So there will be a pus pointing, but the actual lesion is a large nodule and it's very painful. Sometimes they may even have constitutional symptoms and fever. So among these bacterial infections, the treatment depends on how severe the infection is. For the impetigo, usually giving a topical antibiotic, either fusidic acid or mupirocin, does the job, and you don't need to really give an oral antibiotic unless the child is very toxic, has got high fever, and many extensive lesions are there. So most of the time, just a topical antibiotic does if it is limited lesions. If there is extensive lesions, or if there is folliculitis furuncle, then we go for antibiotics depending on whether it is methicillin, like whether it is a normal patient or an immunocompromised patient. Usually hospital-based patients who are diabetic and coming for other conditions like renal failure, kidney failure, or liver failure, they also are immunosuppressed. So they require to be checked even for MRSA, and the antibiotic choice is made accordingly. So first we decide whether this is just a community acquired. In that case, we just give either the penicillin group like cloxacillin or cefalexin or ciprofloxacin in adults. But if it is a MRSA which is suspected, then we need to go for higher antibiotics. So coming to the next type, that is cellulitis. So when the infection reaches the subcutis, person develops a whole limb erythema, edema, severe pain with fever, but the margins are not very well seen. So this requires, most of the time, if it is very limited, you may try oral antibiotic, usually cloxacillin or augmentin. But in most cases, you'll have to go for IV antibiotics, which usually includes a combination coverage of both gram-positive and gram-negative. And this cellulitis will have some blistering on top from which the pus is coming. That will be sent for a swab. So sensitivity pattern helps you select an antibiotic better so that patient responds better. In MRSA, usually we give vancomycin, linezolid, clindamycin, and for pain relief, paracetamol and magnesium sulfate dressings are done so that the edema can be reduced. So this is the treatment of cellulitis. Now, any of the pyodermas which I told you about, impetigo, contagiosa or bullosa or folliculitis, if they are not treated early enough, they can leave scabs like this, which are called ecthyma. So if they are in the healing stage, they may not require any treatment except cleaning and dressing. Now, this is something which is serious for pediatricians because a simple innocuous staphylococcal infection has two problems. One, it can cause streptococcus infection, can cause post-streptococcal glomerulonephritis in children. Second thing is this staphylococcus, the toxin can produce something very toxic condition called staphylococcal scalded skin syndrome. So where the skin starts peeling, and how to recognize it, it starts with fever, child is very toxic, sick, skin is tender, and the peeling of skin is seen around the oral and the genital area. So that's called periorificial and body fold peeling. Treatment will be IV cloxacillin. So that was all about bacterial infections. Now coming next to the fungal infections. I know they practically say that in India now is undergoing now a fungal epidemic and most of the antifungals are resistant, but I would like to say some things after initial introduction. So I'll be talking about dermatophyte infection, which is called tinea or commonly ringworm. Tinea versicolor, which is caused by malassezia and candida, and nail infections. So coming first to Tinea corporis. Tinea corporis is called so as ringworm because of the annular lesion. It presents as circles. So you can see the advancing edge is there. It is scaly. In the center, it may even clear off. In fair patients, there will be erythema. This is an extremely itchy condition. New lesions keep appearing, and patient, as they scratch, they spread the lesion through their nails. This dermatologist will do a KUH for diagnosis, and some of the tinea will be like this, where the scaling is throughout. So what clinches the diagnosis is that it is itchy, it has got well-defined margin, it has a scaling which is very fine and very less compared to psoriasis, and the erythema is also very minimal. So these are usually treated depending on, I will come to the treatment later. Second presentation is when the dermatophyte infection is in the folds. So here you can see the erythema very clearly. Here the skin is very thin, so the erythema is seen well. And this is when the scalp is infected. So this happens usually in children. Adults don't usually get tinea capitis. So scaling will be present with loss of hair in the scalp. Treatment is decided based on how severe the infection is, meaning whether the body surface area that is involved is less than 5% or more than 5%, and if nail and hair is involved. If nail, hair is involved or extensive tinea dermatophyte infection is present, then they need systemic therapy. Those who have localized, means a palm size area, 1 or 2 palm size area alone is involved, then you can try for topical antifungals. That mainly includes two. One is this azole. So you can see a whole long list of antifungals. Most commonly, many of you will be using is clotrimazole and ketoconazole. Many newer ones are available which have a better antifungal sensitivity pattern, but you should always try first with clotrimazole, and if not working, then systemic antifungal can be given. Among the systemic antifungal, there are 3 drugs. First, terbinafine, 250 mg per day. If does not work, then we go for itraconazole, 100 mg per day. But you have to notice that the duration of treatment is important here. Even for topical therapy, the treatment has to be given 2 weeks beyond when the scaling and erythema has disappeared. Itching does persist for a longer time. So still the patient has any evidence of inflammation, they need to continue antifungal 2 weeks beyond clearance clinically. This is very important. Otherwise, there is a static phase and then fungus starts growing again. Why it starts growing again is because the factors which are predisposing the patient to the fungal infection, like diabetes, moisture, heat, sweating a lot, wearing very close, tight clothing or tight underwear, these factors are not removed. So you have to advise the patient about removing the factors and also ensure that the treatment is given for the correct duration. So usual treatment for terbinafine is 4 weeks, and then you assess the patient and decide to continue beyond either oral or topical, depending on how the response is. If terbinafine doesn't work, we go for itraconazole. Fluconazole is also useful, but usually we prefer terbinafine and itraconazole as the first choice, since a lot of resistance is being reported to azoles. In tinea capitis, the drug of choice will be griseofulvin. Tinea capitis means scalp infection. Coming to malassezia. Malassezia, many different species are there. They cause something called Tinea versicolor. This, as I said, that they have very macules. So there is either a hypopigmentation because of the fungus, the melanin production is reduced there because of the azelaic acid produced by the fungus. This pigmentation is not going to go because you have treated the fungus. In the other variant is where you have hyperpigmented variant. Tinea versicolor can present with multiple macules which are mildly scaly, and they have polycyclic margin because the fungus grows again wherever there is lot of sebum. So that's why the hairy areas will have this infection, trunk, face, and when they join together, they have this polycyclic margins. Okay, so that is the way to recognize Tinea versicolor. It's a very common fungal infection of the chest, back, and face. How to treat it? Mostly we treat it with topical antifungal shampoos or lotions. Common ones are clotrimazole and ketoconazole. Although very severe infection, itraconazole 200 mg daily for 5 days can be given. This is candidiasis. So any skin fold, when the moisture is there, candida, which is a normal commensal, tends to grow. Also, those who are diabetics, they are predisposed to impetigo. Those who are obese, they are also predisposed. So you can see that there are satellite pustules, which tells you otherwise KOH can be done, which will show the yeast in the KOH examination. Treatment usually creams, clotrimazole cream twice a day application for 2 weeks is sufficient. Although fluconazole start doses of 150 mg also can be added. And some people, because they sweat a lot, they like to use dusting powders. So clotrimazole dusting powders, ketoconazole dusting powders are also available. Miconazole is also available as dusting powder. Other forms of candidiasis is in a child as oral thrush. So here mouth paint is given. Vulvovaginal candidiasis, where either start dose of fluconazole 150 mg can be given, or pessaries, 2 pessaries per day for 3 days or 1 for 6 days can be kept intravaginally. This is a very extremely itching condition. Mostly many of the patients go to ogicians. And this is when the candida is there in the folds of the toenails. So here, keeping the feet dry, wearing open footwear, and giving a break so that the moisture is reduced, and applying topical antifungal does the job. Now, some people have asked questions about nails and paronychia, so I'd like to cover that. Onychomycosis is the condition where you see thickened yellow dystrophic nails. It's cosmetically disfiguring, and if associated with paronychia, there is pain and inflammation of the surrounding proximal nail fold, which is called paronychia. Onychomycosis could have three causes. It could be candida, it could be dermatophyte infection, or it could be non-dermatophyte mold. Here also, dermatologists usually take a KUH smear, which you can send in any microbiology lab, so that the correct treatment can be given. Provisionally, you can treat it with pulses of either terbinafine, which is given 250 mg per day, daily for 2 to 4 weeks, and see the response, because nails grow very slowly. Toenail require treatment for up to 3 to 6 weeks, and fingernail require treatment up to 6 months to 1 year. So that's why if there's a single nail is involved, then there are nail lacquers available like amorolfine or cyclopyroxylamine. So they need to be painted every week on that nail after cleaning the nail. But if multiple nails are involved, then you have to rule out any immunosuppression, diabetes, and give systemic antifungals. Usually itraconazole or terbinafine are used. Now here, word about paronychia. See, there are two types of paronychia. Acute paronychia, usually following a trauma. Like you have paid, some people peel the lateral nail fold. So from there, the infection gets in and there is a swelling which is very painful. So this condition, oral antibiotic will work. Any penicillin can be used or cephalosporin can be used. Or if there's a pus formation, then it has to be released, then only the pain will go. But when these mostly women and people, farmers and people who work with water a lot, have lot of water wet exposure, they develop hypertrophy of the proximal nail fold like this. So this is because the candida is always present. They also there is a hypersensitivity response to the candida presence in this nail fold, and hence we usually treat it by giving weekly dose of fluconazole for 4 weeks and by topically applying Candid B lotion. This is the only condition where we say that yes, antifungals can be combined with steroid. Otherwise, it is dangerous to give antifungal with steroid combination in the crura. Once you do that, the fungus will not respond well. It doesn't really help itching of the patient much. It totally destroys the original morphology of the lesion and makes diagnosis later very difficult. And when the patient continues applying the combination steroid antifungal for a long time, what happens is the skin over there becomes atrophic, telangiectasias comes, and it looks very ugly and they develop striae. So try to avoid giving steroids in crura folds, and treatment of any fungal infection should be with a pure antifungal cream or oral, and do not combine steroid over there. That is very essential for you to know. Two common parasitic conditions are scabies and pediculosis. So this is, I think, all of you would have heard during your MBBS. It's caused by a mite. Now here, it's important that the distribution is very classical in those who have extensive. There are people who have scabies in clean and they do not have this kind of very typical distribution where the web spaces and all the flexures are involved. So examining the full patient, they have intense itching, which is present more at the night, and multiple family members or friends will be usually having this condition. So this history of nocturnal itching and family members involved has to be asked. There are many people who bring their children and they say none of us have scabies. So it will be the maid or an elderly one who's taking care in the house of the child who has transmitted scabies to the child. Now treatment wise, it's important. 5% permethrin usually is very, very effective. It has to be applied from below neck after bath, a warm bath, finish dinner, and then you have to give a 12-hour contact period. So because you will be applying this lotion between the web spaces on the hands, and they should not touch eye or the oral cavity. Hence, you have to advise the patient to apply it in the night after dinner and then apply it all over the body, giving special attention to all the folds so that it's taken care of. Still, itching may persist for some more time. So after a 10-day gap or 1 week gap, it can be repeated again. And why I have kept this picture is so that you can understand that apart from this classical lesion is that burrows and excoriated papulopustules in the web spaces, involvement of genitalia is classical in scabies. Second parasite is pediculosis. All of you know. Main thing is to know that treatment available are 1% permethrin lotion, which has to be repeated twice, separated by 1 week or 2 weeks, because it's not effective on the eggs. It's effective only for the louse. So when the new eggs, from the eggs, the new louse hatches, that needs to be treated again. Hence, it requires the treatment to be repeated after a gap of 1 or 2 weeks. Also, Septran and oral ivermectin can be tried. Now, going on to the viral infection. So this is something that many of you will be knowing about. This is caused by varicella zoster virus. It's commonly called chickenpox. You see, erythematous base, there are vesicles. Later, they may become pustula, but most of the time you see clear vesicles on an erythematous base, which comes with fever and malaise and spreads all over the body. Treatment has to be started within 48 hours. Otherwise, acyclovir is not helpful. So start the treatment. The dose is higher than what you give for herpes. And if 5 times a day is difficult, then you can take valacyclovir BD dosing for 7 days. When this varicella zoster heals, chickenpox heals, it tends to localize to certain dermatomes. And during any episode of stress or fever, high fever, even COVID, they can reactivate from the dorsal root ganglion to present as vesicles and pustules in a dermatomal distribution. So this is in a dermatome. So that actually helps you clinch the diagnosis. Treatment is same, acyclovir 800 mg 5 times a day for 7 to 10 days. But some people have asked me about post-herpetic neuralgia treatment also. Here, what is important is that acyclovir or valacyclovir, whichever you choose, give it early enough for 48 before 48 hours and give it for a duration of 7 days. Early enough, you can start pregabalin or gabapentin because they are neuroprotective. So that if the nerves are not damaged, the chances of them developing a post-herpetic neuralgia is less. And many drugs are available. Usually we call it post-herpetic neuralgia more than 6 weeks later. Till that time, analgesics can be given, tramadol, or don't try taking too much of NSAIDs. In post-herpetic neuralgia, now capsaicin patches are available. Some people used to do, if it's very severe, anesthetists can do pain relief by cutting the nerve. Sympathetictomy can be done. But mostly drugs are used. So very useful drugs are carbamazepine, amitriptyline, gabapentin, pregabalin. Coming to herpes. Herpes presents in the first episode as fever with lymph nodes, and the vesicles will be present over the lips like grouped vesicles. And after 3-4 days, they will become crusted and dry and heal. But some of them may have very severe presentation like this, herpetic gingival dermatitis, when the patient requires. All these people need to be given tab acyclovir 400 mg TDS for 7 days for the first episode. But recurrence is very common. Every time they have fever, they'll have a milder presentation of herpes again. So at that time, they can be given for 5 days, same acyclovir. Herpes also causes genital ulcer. So here you can see grouped vesicles. So when they rupture, they form erosions. And because they are joining together, they have serpiginous margins. So this is what helps clinch the diagnosis. The second viral, we have covered chickenpox and herpes simplex. Now this is about verruca. See, verruca is difficult for a primary care unless there are just 1 or 2 lesions which can be either PARD or salicylic acid paint can be given and they can be PARD. Apart from that, they need destructive therapies. So for if the lesions are few, usually cryo or electrocautery is used by dermatologists to remove them so that you ablate the lesion. And this while ablation, the body's immunity is triggered because HPV is present in the superficial layers. So when you do the ablation, the immunity will get triggered and it takes care of the viral infection completely. But in some cases where it does not take care and somebody has extensive verruca vulgaris, in those cases, immunotherapies are tried. This is an example of human papilloma virus causing a genital wart. So this also usually destructive therapies, but in pregnancy. But apart from that, usually there is something called podowart, podophyllin resin, which is available, which is painted over the wart twice a week and results in resolution in 3 to 4 weeks. This is molluscum contagium vaster. This you must have heard about it because of the typical appearance of umbilication in the center. So this is common in children. Curettage can be done, but TC application of 5 to 10%, KUH application is what dermatologists give. But if there are not too many of them, they can be left alone also. So with this, we have finished all the infections which are common in primary care. Now I will talk about few of the inflammatory dermatosis. A lot of questions were about psoriasis. So how to recognize psoriasis is, as you can recognize, the scales are very thick and they are white and they are micaceous, means they can be peeled off. And the lesion has a degree of well-defined plaques which occur with a degree of redness. So that helps clinch the diagnosis. Usually lesions will start as papules and coalesce to form a plaque. Very itchy condition, but more than the skin condition, what is worse is that it is associated with psoriatic arthritis. The psoriasis forms are many. It can affect scalp, so that's called scalp psoriasis. It can affect the nail. It can have a generalized form which is called unstable or psoriatic erythroderma, and pustular psoriasis, in which you will not see any of these plaques. Only pustules will come, crops of pustules will come with high-grade fever. So those patients require admission. Some people have asked, how can we treat it in primary care? See, those treatment of psoriasis depends on two factors. Body surface area involvement. Before they used to say 5, now they say 3%. So anything below 3%, topical therapy can be given. Yes, a primary care physician can give. Commonly, steroid salicylic combinations are used in combination with tar or vitamin D3 analogs. So there are 3 combinations. You have tar with salicylic acid at one time and steroid at one time. Another option is steroid salicylic acid at one time and vitamin D3 analogs like calcipotriol at another time. So this can be given in primary care for localized areas of psoriasis. And many people just stay plaque psoriasis for many years. They don't have any exacerbation. It's not like you don't treat and then it keeps on increasing. When they have a flare, usually a stress episode or native medication, or the patient has taken oral steroid is the reason, because the moment oral steroid is tapered, oral or some people get IM kinocort injections for psoriasis. So when that is tapered, then that precipitates a generalized pustular psoriasis and patient becomes very, very sick. So among the systemic therapy, the commonly used drugs are methotrexate, retinoids like acitretin and cyclosporin. Those, they all have side effects. So usually a dermatologist only handles psoriasis cases. Phototherapy does not have much side effects and is very, very effective, because even those who have renal or liver disease, they cannot be given methotrexate, but they can be given phototherapy. The newer drugs like secukinumab and ustekinumab are also being available in India. And if these routine drugs do not respond, then the biologics can be tried. APHTHE. APHTHE is, how will you differentiate it from herpes? Herpes, you get grouped lesions. APHTHE are single, they are deeper, they are covered with white slough, whereas herpes is superficial, grouped, which heals in 1 week. APHTHE usually takes 10 to 14 days. You have to rule out if somebody is having multiple APHTHE over a prolonged duration of time. Rule out any IBD, inflammatory bowel disease, neutropenia acyli, and treatment usually oral hygiene has to be good. Topical kinocort, that's a topical steroid, which is the creams which are applied for the skin are not applied in mucosa. So that's what is applied here. And oral vitamin supplements can be given. A lot of questions about eczema. So how do you recognize eczema different from psoriasis? See, psoriasis is a scaly condition. However much you scratch, bleeding will come. But in eczema, it is a different types of eczema are there, but it starts as vesicles. So when the patient has itching and they scratch, water pours down. So that is called oozing. So when you have a oozy lesion, the diagnosis is dermatitis. Different types of dermatitis are there. So allergic contact dermatitis is what something some people, they in common lay terms, they say allergy is there. So when a common example of that I'll give is person. Sorry, I think I will skip that slide. Some background noise is there. So in allergic contact dermatitis, if some person is applying bindi, then they develop around that bindi dermatitis. Very, very common is nickel dermatitis. Young girls, first time they get sensitized, and then whenever they wear any nickel jewelry in form of earrings or necklaces or bangles, they developed oozing and itching, which water pours down on scratching, and that is a form of allergic contact dermatitis. So in allergic contact dermatitis, either by history, you should confirm the diagnosis, what is the probable allergen. Very common two allergens in India are Parthenium and cement. So they have a whole body allergic contact dermatitis. That definitely requires a dermatologist treatment, but all the localized dermatitis can be easily treated by steroids. So you can start with potent steroids and like betamethasone or clobetasol propionate. It immediately responds in 2 weeks, and then you have to taper it by changing over to a milder steroid. In contrast, in irritant contact dermatitis is something which is like there is a toxic chemical exposure, like acid burns. So the acid burn is an example of irritant contact dermatitis. In children, napkin dermatitis is very common. That is because of the maceration which is caused by either the fecal matter or the urine. We are wearing the diaper for too long. So there they can cause irritant contact dermatitis. Treatment usually is remove the allergen, do not wear for some time, and apply potent see here, in children, it's very important to know what potency of steroid to use. Over the face, only hydrocortisone and desonide is used. Mometasone in adults can be used. But flexures, only these three can be used. Hydrocort, desonide, mometasone. Potent fluorinated steroids like fluticasone, clobetasol, they can not be used on flexures and face, but they can be used acrally. So if there is a discoid eczema or allergic contact dermatitis, there it can be used. Coming to atopic dermatitis, very common condition. Now, most of the children, they have a history of allergy, and sometimes they, in life, first they develop over the face. It can start anytime from 6 months, even as early as 3 months, but not at birth. And this redness and oozing of the face with itching when the child starts walking is on the extensor surface, but as the child grows and becomes an adult, the eczema gets restricted to the flexures. So the treatment is mainly emollients. You have to tell the parent not to use any there are special emollients available for atopic dermatitis which do not have fragrance, preservatives, so that does not add to the allergy. So those emollients have to be used, and they have to be given early treatment, can be topical steroid. Later, once the oozing has reduced, and we also tell them to use some saline compresses. Later, they can be converted from steroid to tacrolimus or pimecrolimus. Newer drugs that are available are dupilumab. In 6 months to 1 year, some children develop this kind of cradle cap. It is basically a form of seborrheic dermatitis due to excessive sebum at that particular age group. So if it is mild, it can be treated with baby shampoo. If it is severe, it can be added, a steroid shampoo can be added. Now in adults, the same thing, seborrheic dermatitis. It's also a form of eczema. So that very mild variant presents just with dandruff. So there usually we use ketoconazole shampoos. But if it is extensive and it is, some people have asked me what is the dermatitis of the eyelid. So that dermatitis of eyelid is usually blepharitis, which is associated very commonly with seborrheic dermatitis or because of malassezia. So there, cleaning the eyelids with baby shampoo is useful, and some warm compresses can be done, and very mild steroid hydrocortisone can be used. Coming next to urticaria. So this there are two types. One is acute urticaria and there is chronic urticaria. Acute urticaria usually is something is infection or some drugs have been taken, especially drugs like triggers like NSAIDs, aspirin. These cause urticaria. So in that case, patient has to be told that you are developing urticaria because you are taking those drugs. Among chronic urticaria, there are two types. One is physical urticaria. Patient just gets any itching, or there are different types of physical urticaria. So that cannot be, they can only be controlled with antihistaminics. You cannot remove the trigger, because whenever they wear bag, the child will get urticaria on the shoulders. Wash clothes, they get it on their palms. So there they need to be treated with antihistaminics. First line is usually cetirizine or hydroxyzine in children. Those who are working, they need non-sedating antihistaminics. So there the options are fexofenadine, belastin, loratadine, and sometimes we can add Montelukast combination to the cetirizine or levocetirizine. A new drug in urticaria, chronic urticaria, is omalizumab, which is anti-IgE. Angioedema. So some of the patients have urticaria associated with angioedema. If it is urticaria associated with the angioedema, it may not require very detailed workup in form of lab investigations, but you need to elicit history. What are the triggers? This is a dangerous condition, since if angioedema, it can very rapidly cause laryngeal edema. So these patients need to be immediately referred to casualty. In casualty, they are usually treated early stages with antihistaminics, and oral steroids, usually hydrocortisone. But if there is fall in BP, oxygen, fluids, and IM in epinephrine has to be given. Coming to two common pigmentary disorders. This is melasma. Main exposure to sun is the main cause. Some people develop it during pregnancy also. So this requires this pigmentation to be removed. There are two options. Either you can use only hydroquinone or sunscreens, or you can add a triple regimen. So in the triple regimen, there is a tretinoin, which peels this pigmented skin, and there is steroid, which reduces the inflammation because of this peeling and the inflammation which is caused by hydroquinone. What hydroquinone does is it stops the melanin production. So that will cause this hyperpigmentation to go away. But mainstay is photoprotection. That means sunscreen should be used every time they step out in the sun. Vitiligo, a lot of stigma associated with, see, this is an autoimmune kind of condition. One thing you have to tell the patient to be happy that other than thyroid and few pernicious anemia and diabetes, they are not likely to have any other associations. They are very healthy. There are different types of vitiligo. They can have just focal vitiligo, small patches. That can be treated in primary care, usually with first topical steroid, second tacrolimus 0.1%. Please, percentage should be 0.1%, then only it will work. So that short course, and then the pigment usually comes back. But when somebody has very extensive vitiligo, presenting as hypopigmented macules with leukotrichia. Leukotrichia means the hair is also white in that area. So then this requires much more, that treatment is tailored depending on how fast the patient is developing lesions and how much can be done. If it is something like segmental vitiligo, where the vitiligo is present in one segment of the body part, then that usually we have to wait for it to stabilize, and then surgical therapies are better. Till that time, tacrolimus can be used. But for generalized vitiligo, focal, we can try these. But for generalized, it is better to go for phototherapy. If there are multiple new lesions coming, then for the acute stage, to control the disease from preventing new lesions to come, oral steroid can be used. Newer options that are coming is tofacitinib. Regarding the surgical therapy, which I told you best is for the segmental vitiligo, and also can be used for focal vitiligo, which is not responding to any topical therapy, which you have tried for more than 3 months. So in that case, punch grafting, blister grafting, and now melanocyte suspension, that can be done. Usually, obviously, dermatologists only will give this. A few drug eruptions. So this is a typical picture of a fixed drug eruption. The fixed drug eruption will happen, very common to many antibiotics. This blue-gray color is very typical, surrounded by erythema around it. Every time the patient takes the tablet, same area, they will develop the same eruption again. Very dangerous. There are few things in dermatology which can kill the patient. One of them is pemphigus. Second is a severe drug reaction like SJS-TEN. And third is going into sepsis or a very bad psoriatic erythroderma or unstable psoriasis. So in this condition, you see there is toxic. Within 1 to 2 days, even a single tablet can precipitate TEN. You should immediately refer to a tertiary care hospital. SJS and TN, both of them, the difference is mainly in the systemic involvement and degree of involvement. SJS means less than 10%. 10 to 30 is overlap, and more than 30% is called toxic epidermal necrolysis. So that mucosa will be involved, multiple mucosa will be involved, eye is involved, oral is involved, nasal crusting will be there. Much worse in TN, they can have lung involvement. That's why they will develop ARDS, and there will be toxic injury to the kidneys, so they can develop ATN, and patient will be very, very sick, so they need to be referred to a tertiary care. A very common doubt was about acne. So acne, I think everyone knows how to recognize, but how a dermatologist differentiate it from many other conditions is by the presence of these comedones. So this is a open comedone, this is a closed comedone. So presence of these comedones clinches the diagnosis, and treatment depends on the type of acne and how severe it is. If it is a very mild acne, just this much, then just benzoyl peroxide is enough. If there is predominant comedonal acne like this one, then retinoids in the form of either tretinoin or adapalene is useful. Most of the time we give a combination because benzoyl peroxide is also anti-inflammatory and antibiotic. So that is given at one time, and at one time we exfoliate the comedones by using retinoids. That is topical therapy. But if someone has large nodulocystic acne or has extensive truncal acne, then oral treatment is available in form of tab isotretinoin, and that requires a 3 months of treatment to control the disease. And for nodulocystic acne, which is very painful, intralesional injections can be given into the acne plaque or nodule. So usually we use combination of either benzoyl peroxide or retinoids like adapalene to treat acne if it is mild. But if someone has severe acne, first a oral course of antibiotic, usually either minocycline or azithromycin is given. So you control the inflammatory lesions to some extent, and then they are put on a course of oral isotretinoin. Usually 20 mg or 10 mg OD you start with, and continue the treatment for 3 months till all the lesions clear. Regarding lesions in SLE, how do you differentiate this from melasma? The melasma, which I showed you, is just a pigmentary condition. There is only change in color. There is no inflammation. There is no itching. There is no photosensitivity. The rash in malar rash is a butterfly rash which is distributed over the nose and onto the surrounding cheek area, sparing this protected nasolabial region because there the sun is not getting in. They also have oral ulcers, and they'll have something called discoid rash. Difference between a malar rash and discoid rash is malar is always acute, a discoid rash is chronic. Discoid rash is pigmented, it can be scaly, and also present only up in the head and neck region. How do we treat this acute rash? Both malar and discoid is treated with photoprotection and topical steroid. All SLE patients have to put on sunscreen and hydroxychloroquine and work up for systemic problems that they may have. And treatment is basically tailored on the systemic involvement. So this is what I acknowledge my Professor Dr. Thapa. Many of the pictures they have contributed, and Dr. Kanmani Indra have contributed. So with this, I will stop the screen share. And we can, I hope I could convey all the infections, psoriasis, vitiligo, melasma, the dangerous drug reactions, and acne. vitiligo. So hope you got.
Yeah, thank you so much, Professor Dr. Rashmi Kumari, for such an elaborate talk. Very informative, very interesting session, ma'am. And I'm sure we have learned many new things today. So we have, yeah, sure. So we have few questions in our chat box. So Dr. Sachin Patel from Ahmedabad, inflammatory acne, he is asking for inflammatory acne treatment protocol.
Okay, so inflammatory acne we refer to is when you have a lot of papulopustular acne. So I think you understood papules is that red one, pustule is the one which has pus. So usually if there's a lot of inflammation, lot of papulopustular lesions, a course of antibiotic, minocycline or azithromycin is given. But that's not going to take care of acne completely. See, acne is coming because of hormones, and there are comedones which are going on coming because of those hormones. So you need to take care of the comedones. Either topical retinoid in the form of adapalene or retinoid, or if it is very extensive, involves the trunk, then systemic retinoid in form of isotretinoin. That is the treatment. In addition of oral treatment, the topical is also continued in certain patients. There is concentration of lesions, mostly benzoyl peroxide. So those who have very mild, we use only benzoyl peroxide. The one who have inflammatory form of acne, I mean, if you are referring to a severe acne pattern, papulopustular or truncal, then oral isotretinoin. There are some who have this painful nodules, which cause very bad scarring. So if they come early to us, we'll give intralesional, intralesional steroid into the nodule, which will make the nodule resolve. But oral steroid is not given, topical steroid is not given. Topical steroid will cause steroid facies, and once a patient has touched a potent steroid on the face, they won't be able to stop it. I mean, it destroys their face. They'll have something called steroid facies, a red face with a lot of telangiectasias and atrophy. So avoid that. Don't get into that.
Thank you. Another question from Letha Thomas, Delhi. What is the effective treatment for dry skin?
Yeah, so see dry skin generally requires, who has dry skin? Either they have some ichthyosis condition. So what is ichthyosis condition, which is most common? Ichthyosis vulgaris. So they'll have dry skin usually only on the extensor, means the lower legs, and on forearms sometimes. So they need to basically winter apply a lot of thick emollients. But if the dry skin is associated with atopic dermatitis, or if then they need to remember that any emollient will work if it is applied immediately after taking bath. So you should pat dry your skin when you are in the bathroom and keep the bottle in the bathroom and apply it before the water evaporates. If the water has evaporated, then the oil cannot protect anything. So no moisture will be retained. If you want moisture to be retained, take bath, preferably lukewarm water, not very hot water, not very cold water, and immediately after bath, apply liberal emollients on face, hands, and feet. That will take care of dry skin. But if somebody has really bad dry skin, which is not responding to emollients, they need to rule out things like hypothyroidism. They need to find out if they have a condition of ichthyosis.
Thank you. Many questions for monkeypox. Dr. Pragya Rani from Kolkata and Shima Razi Samir from Birmingham want to know about the current guidelines for in managing monkeypox, and please highlight treatment options in monkeypox. Along with one more question in monkeypox from Dimuth from Newcastle: how to differentiate papules of monkeypox from other disease papules?
Okay, so for that, I'll try to, can you see my screen? Is my screen visible? No.
No.
So for a second, I will try to, just a minute. I will try to share some pictures of monkeypox and see. See, monkeypox, main thing, they should have it's almost they have to have some foreign travel or some contact because they need to get it in India. There are only so far 9 cases have been reported. We are having many CMEs on monkeypox also. Monkeypox lesions will be papules, start as papules. So I'll show you some pictures of the evolution. See, it may start as papule, become a pustule, but then you see there's a ring of edema around it. And generally what happens, this is a lesion of monkeypox. So you have elevated induration around it, and then it crusts. It takes very long to heal. It's very, very painful. Patient will usually have fever, lymph node. Lesions can be present on the face or on the palms or on the genitalia, but there's nothing classical. They can look very much similar to any pyoderma, but at least to some extent in the beginning stages, they have this induration around it. They are very painful, excruciating painful. They may have a history of foreign travel or contact with somebody who has had monkeypox, and they may have possibility of the sexual history should be explored if they have any MSM contact, means men who have sex with men. That needs to be ruled out. So you see some lesions over the, I'll show some lesions over the penile shaft. See, it started as pustule and then it became umbilicated. It's got a crust in center. It's got an indurated, means elevated firm edge, and surrounding lymph nodes will be there. They have, this is the typical appearance. It almost looks like smallpox, but smallpox is very, very, very contagious. This is not that contagious. This requires very close contact, and the lesions will take 3 to 4 weeks to heal. So till it crusts, they need to be in complete isolation. The guidelines are given by Government of India. First thing, you need to identify, send their blood and urine for monkeypox testing to ICMR Pune lab. And once the treatment is confirmed, most of them will have few skin lesions, but they can have a generalized rash. They can have lesions only on the palms and soles, and they can have just fever and a maculopapular rash. So main thing is to suspect. And if you suspect, then you find the regional lab for your state. There will be a designated lab for your state. You send the case to them. So they isolate and they test it. And the treatment, newer drugs are available. There is cidofovir, one new drug has been brincidofovir and ticovirimab. These are the 2 new drugs. And obviously all of us, like I am vaccinated for smallpox because I was born in 78. So 77 itself, they are almost winding it up. But somehow those who have got, all adults older than me, they are having partial protection probably due to the smallpox vaccine. Vaccines are available. Drugs are being considered. So if it comes to India, they usually need to be isolated and cleaning and dressing. For skin lesions, only that much needs to be done.
Yeah. So we have many more questions in the chat box, but I don't think we are left for more questions, time for more questions. So thank you again for such an informative and insightful presentation. And over to Simi. Thank you.
Thank you so much. Thank you, Dr. Rashmi. That was a great, very informative session, and I think equally engaging question and answer. Wish we could have more questions, but I can see the questions are pouring. There are so many questions. I think I'll not do justice. There's one question which I would like to address because that has been continuously asked while I was just going through. So yes, so there's a question from Madhavi from Hyderabad, and she's written, most topical antifungal drugs are available with corticosteroids. And the claims are that the combination will reduce inflammation and helps in faster response.
No.
So she wants to know.
It's wrong. Once you give a combination steroid and antifungal, the antifungal will not work to its capacity. Its name is Tinea incognito. That condition is called Tinea incognito because the steroid will mask the inflammation, means the redness will go, the scaling will go. The itching will persist. To some extent, it comes down in the beginning, but the fungus keeps growing. Once you give steroid over there, the fungus will grow. It will only become more extensive and more difficult to treat later, even become antifungal resistant. You will have to go for, the moment we get a case of Tinea incognito, treated with combination steroid, we have to give oral antifungal. Oral antifungals are usually safe, but prolonged treatment, you need to check liver function tests, especially for itraconazole. So, and even for terbinafine. So, not correct. There is, I have actually in my presentation, I have shown you the list of antifungals. Just a minute. I have shown a long list of antifungals. All of them are very much available. You can't say that clotrimazole. Yeah, right. Just a minute. I think I am there. So here it is. The antifungals, clotrimazole, ketoconazole, most commonly used. Basically, ketoconazole is used as shampoo. But you see all these drugs, iconazole, miconazole, oxyconazole, sertaconazole. Very commonly now people are coming and talking about luliconazole and ibuprofen. These are available plain. And you use plain antifungal only. If it is extensive, see anything which is going more than 5% body surface area, also nails are infected or extensive tinea is there, palms and soles are involved, you have to go for systemic treatment. So in that case, go for terbinafine or itraconazole as the drugs. So, and treatment is 2 weeks beyond clinical complete clearance. How do you make out the clearance? The pigmentation will remain sometimes, but the scaling, erythema, and the advancing edge and the symptoms come down significantly. If you stop beforehand, if you just stop with 2 weeks treatment, tinea just comes back.
Sure, I think I have tried to merge so many questions, but this was one question which was repeatedly asked. So thank you so much for answering that.
And also don't use neomycin. Neomycin is a very strong allergen. So when you use neosporin powder, neosporin cream, many of this quadiderm or the steroid creams, they have neomycin added. It is sensitizing the patient to neomycin. And then they develop allergic contact dermatitis, especially patients with venous eczema. Venous eczema, I think everyone knows about it, varicose veins related eczema or ulcer. Please don't use neosporin extensively.
Thank you so much for that extra piece of advice. And I have enjoyed myself so much with so many common conditions, which we have beautifully classified into infections, inflammatory, and other things. We sincerely hope that we have met participants' academic expectation. Please share your feedback with us. It is not going to take more than 40-45 seconds, but it will help us to shape our future events. Thank you once again to all the participants who have taken time from your busy schedule and join us for the webinar. This brings us to the end of today's webinar. And before we conclude, we'd like to remind you once again to refresh your page, to download the certificate of participation from the tab button that's popping on the screen right now. So thank you once again. And till we meet again, stay safe and take care of yourselves. Have a wonderful evening ahead. Thank you so much.
Thank you.